This conference will now be recorded.
I googled suggestive flowers, and this is what popped up.
Did you watch Mr. Deeds yet?
No.
We've been busy, bro.
Tell people quit dying and then go watch this.
Yeah, that'd be nice.
That'd be cool.
Our balance here is slowly transitioned from everybody calling Mike every time something goes south to everybody calling me and Becca every time something goes south. So, man,
We're
just because they don't want to bother you. Alyssa's like, frick yeah.
Yeah, he spent the last, years? Yeah, he spent the last years doing that.
Yeah. Now they call us at midnight and they're like, we need help. And I'm like, man, I don't wanna. Did you start recording the meeting?
Yeah, I started recording the meeting. Huh? It does look like it. It's supposed to be a placenta, I think. With the little umbilical cord. I don't really know. I know it's not supposed to go with that.
So this is one of two of the most highly failed sections of National Registry. The second section is EMS operations.
Yep, that's next week.
So pay close attention, do your studying. I know it sucks, but this is the most failed portion of National Registry.
Yeah.
Statistically.
If you guys are taking those medic tests or the pre-tests or whatever, and you come across something that you feel like we need to cover in class as a group, text me, write it down, show it to me. I want to do, like, whenever we get done with the book work, I want to do like presentations on whatever you guys think. So we can just go like deep dive into the weird random stuff. So, like we said, we're going to split this up. It was supposed to be 2 chapters tonight, but we're just doing the one. We went back and forth like 3 times, but there's just a lot of information in here, and we don't want to overload y'all. So it just pushes our days of doing book work one more day.
And just so y'all know, we're going to pick a random day sometime, and we're going to dedicate that entire day to GCS scales.
Yes.
We're going to build GCS scenarios, GCS numbers, get you in the habit of calculating that GCS scale, because that's another big failure point on National Registry. People go in and don't know those numbers, and it kind of screws them, as we saw last week on that test.
Yeah.
So we can go over the APGAR, and I think, is that part of this too? Yeah, APGAR will all be in here. We can do some APGAR stuff. That one's a little easier to remember.
Yeah.
So.
Yeah, APGAR, appearance, pulses, grimace,
respirations.
All right, so everybody's favorite chapter. And I swear, if we go over this and I deliver a baby this week, I'm going to be mad. All right, so our objectives. Review A&P of the female reproductive system. Determine key points of assessing a pregnant patient. Learn the process of stages of delivery.
Mike Ram. Sorry, go ahead.
The stages of delivery always throw me off, because I think that 3 should be when the baby's born. So we're going to go over that. All right, so female external genitalia. This is going to be, we have a little model over here too. So
I just feel like you need to sit in here so you know how to not make this happen again.
What is that?
That's the thing that cost you all that money last year.
I got 10 grand back from my taxes.
All right, so this is our uterus, right? Our little ovaries, our fallopian tubes. Our cervix sits right here, kind of that dividing point of the inside of the vagina. So the ovaries produce the ova, and then the oviducts are where this, in here in the fallopian tube, is where the fertilization occurs. So in a perfect world, the little egg gets fertilized and travels and implants on the inside of the uterus, hopefully, right? Does anybody remember what happens when it implants outside of the uterus? Good. So Ectopic pregnancies anywhere outside of the uterus. The most common place is the fallopian tubes. Why is this dangerous for the patient?
Because their muscles, so like it doesn't push out. So like
Yeah.
they burst and they can bleed out.
Yeah, exactly. They can bleed out. So remember, any female within childbearing age that has abdominal pain has an ectopic pregnancy until proven otherwise, right? The cool thing, not cool thing, cool thing about ectopic pregnancies, they can go, because there's a little gap here, they can actually travel outside. There's like studies of and case reviews of them implanting on like females' livers and stuff, spleen, that kind of stuff. So kind of crazy. So uterus, not very big. It's usually about the size of a fist. Muscular, hollow organ located midline in the lower abdominal quadrants. Yeah, this is where reproduction takes place. And obviously, whenever there's a little baby in there, this is going to stretch and grow, right? So I found this little sac, and I think that it is meant to be like a uterus and have a little baby in here. So you can kind of see the placenta, and there'd be a little baby in here. It looks like a jellyfish. And then the cervix is that, we talked about that, it's that little dividing factor there. So this is what dilates whenever we're talking about like pregnancy, and as they're dilating, they're progressing in labor, the cervix gets pretty big because it's got to fit a baby's head through it. So in pre-hospital, we do not check if they're dilated or not. That is not a thing for us to do.
Don't
Please.
stick your finger up nobody's hoo-ha.
Yeah. Nothing goes inside of the vagina like a hand, except for one thing. There's one exception. Does anybody know the exception? Pre-hospital. Yeah, to get the pressure off of the prolapse cord. All right, so menstrual cycle, it lasts 28 days. So we have different phases of our menstrual cycle. Everybody, when they hear menstruation, they just think of the bleeding. That's just part of it. So this whole cycle lasts 28 days, or about a month. This is the worst part, obviously. This, between this and this. So usually lasts 3 to 8 days. That's dependent on the female. Whether this is regular or not is also dependent on the female. And then our little ovaries are like, here, I made this beautiful little egg for you. Why don't you fertilize it? And then it doesn't get fertilized, and then it's like, frick you, and then just destroys everything else. So 28 days. Stimulated by estrogen and progesterone are the two main hormones that are used in this cycle. So yeah, here's just another like visual of that cycle. It's a little easier to see. So 1 to 7 days. The follicular, ovulation, and luteal phase. So what phase of this is your chances as a female of getting pregnant? The ovulation phase. Yep.
I feel like these are like the cycles of the moon. That's what it
Yeah.
sounds like.
Yeah. We have a full moon tonight. All right, so fertilization, that sperm reaches the ovum. Whenever one breaks through, all the other ones get like expelled away from the little ovum. And then as it develops, it turns into an embryo. So those cells start to divide and start to grow. That embryo implants in the uterus, hopefully. That's what we're wanting, right? That's what you want, not outside of the uterus. And then the fetal stage officially begins at week 8. Pregnancy, 9 months of pregnancy. They're split into 3 trimesters. So you have your first, second, and third trimester. Knowing which things to look for in each trimester. So like your eclampsia and preeclampsia, those usually develop like later, second, third. Those don't develop in the early trimesters. So if you have somebody that knows about how many weeks they are pregnant, these are things you can kind of keep in the back of your head. And then the placenta is formed. So placenta is pretty cool, right? This is a whole organ that the female body grows while they're developing a baby, which is pretty impressive. It supplies blood, nutrients, oxygen to that little baby. Where it goes into the baby's belly, in their little belly button, it actually goes like directly into the liver. So that's kind of a cool thing that shuts like immediately as the baby's born and that placenta is delivered. Waste products are changed there. Whenever you're delivering a placenta, um, it wouldn't be so bad if it wasn't warm. Like, that's the worst part about it. It's like floppy and warm. Make sure that, yes, people eat them. Yeah, yeah. There's also people that do, like, they call, I think it's called a lotus birth. So they have the baby and they deliver the placenta, and they keep the placenta. They never cut the cord. They just let it fall off naturally. So there's like just chilling with this placenta. But yeah, it is a little strange. I don't know. Yeah, the eating of things, very strange. So, ooh. Not personally. Not personally. Apparently, you can get it like dehydrated and put in pills and all sorts of stuff.
Make like a mean tea out of it.
Yeah. All right. So pregnancy, there's part of your umbilical cord, so that's what delivers the nutrients to the baby. The length of the umbilical cord is not all the same across the board. So sometimes the umbilical cord is really long, sometimes it's really short. Sometimes it's so long it starts to wrap around things that it shouldn't be wrapping around. About the umbilical cord. Oh no, it's a lot of umbilical cord. That's a lot of baby. So a thing that's kind of came from like recent studies and everything is you actually wait for that umbilical cord to stop pulsing before you cut it. So that's going to be dependent on the mom if she wants that, and like baby stable and mom stable and you don't need to cut it right away, go ahead and like follow her wishes, right? Because this is her birth, this is her birth plan. You're going to respect the mom or the family or whoever's doing it. And then the amniotic sac, that's what keeps the baby. The amniotic fluid keeps the baby afloat. It cushions the fetus, provides protection, and then also maintains like temperature of that baby. Yeah.
So we were talking about like abdominal, like that's going out. You want to keep it sterile
Mm-hmm.
and like moist.
Yeah.
Would you do the same if like the mother wants to keep the placenta out with the baby, or just keep that?
No, I think the whole purpose of that is to dry it out.
To let it dry out, yeah,
Yeah.
I think so.
It's
And
kinda
they'll like
like,
put like herbs and stuff in there.
Yeah, it's
That's
kind of
what
like the
everybody-
goat whenever you rubber band their nuts, and then eventually it dries out and falls off. It's kind of the same concept. Right? Isn't it the same concept? You're just waiting on it to dry off and fall off.
Yeah, I guess. I would ask them. If someone wants to do that, I'm sure that they have done research to do that. So I would just ask them. Is it considered cannibalism? I guess it would be. Yeah, 100%.
Yeah.
All right. So physiologic changes in pregnancy for the mom. So cardiovascular system is affected. We have an increased blood volume, increased cardiac output. So the heart's pumping more fluids, and then the increased heart rate. So it's not abnormal for your pregnant patient to be sitting at a heart rate of 110, 105. That's their normal resting heart rate at that point. Respiratory, they have an increased oxygen demand. They're building, they're so crafty, they're making a whole new baby, right? So more oxygen demand, more oxygen consumption. And then the GI system, obviously, everything's getting squished in there. There's a lot of different hormones. So slow digestion, nausea, vomiting, everybody hears like the morning sickness kind of thing. That's why. So look at how squished everything is in there. Yeah. Bless you. All right, hormones. So I think it was 2 classes ago we talked about the hormones that are released that make ligaments more bendy in pregnant patients, especially in the later trimesters. So they're more vulnerable to injury in their joints. And the purpose of that hormone is to help that pelvis kind of stretch out and be able to deliver that baby. Additional weight is going to affect posture and their balance as well. So they're kind of more prone to injury in that sense as well, because there's like a little weight distribution that's going on. And then if they have any pre-existing medical conditions, make sure you're asking about that if you go on a pregnancy patient, because their pregnancy might exacerbate our current conditions. So here's just a couple things.
Oh, she pregnant.
She pregnant. Yep. Yeah, she's really pregnant. So shortness of breath can be common. Increased oxygen demand, we talked about that. Belly's getting bigger. Nausea, vomiting, heartburn. These can be like, some people may have these symptoms, some people may not. But this is kind of like a generalized signs and symptoms that you might see with the pregnancy. So one thing with pregnant patients that are pretty, like if they're visibly pregnant, like in their second or third trimester, and they're starting to get that baby bump, whenever you're transporting a patient and you need to lay them flat, never lay them supine, right? Does anybody know why?
What
Kinda.
happens? What
Yeah.
happens to the baby whenever you lay them flat? Everything kind of.
Whoop, everything comes up. So it squishes the little IVC, which is your inferior vena cava. It can cause hypotension, which is supine hypotensive syndrome. That's where that comes from. How do you combat this? Yeah, the left side. What if it's like a cardiac arrest patient, pregnant patient? What are you going to do? Because they got to be supine, so you can move the baby. Yeah, you can manually move the baby to the side.
And that was on Becca's National Registry.
Yes, it was multiple times. So this kind of just is a visual representation of that baby. It's squishing the IVC and the aorta. It's going to cause decreased blood flow, dizziness, hypotension, shortness of breath. Just moving them a little bit to the side takes that baby and takes it off the compression off of those arteries and veins. All right. What's stage 1 of labor? Regular contractions, and ends whenever the cervix is fully dilated. Does anybody know how many centimeters that is? 10 centimeters. What's the second stage? Birth of the baby. Good. Yep. So baby enters the birth canal. Baby is born. This in my head is like, this should be the third stage, but it's not. What is the third stage? The afterbirth. Yep. So the placenta and all that goodness just gets out of there. Yep. So here's a little picture. Initial phase, gets dilated, baby comes out, then the placenta. Does anybody have a guess on how long it can take for like the afterbirth to be delivered? Yeah, about 30 minutes. Good job. All right, so a lot of times when you get called for pregnancy calls, and they're in the later stages, you're going to get called for contractions. So whenever you're assessing contractions, one good thing I like to do is just have the mom like, okay, let me know whenever your contraction starts. And I start the timer. And I note the time and I start the timer. And then they let me know when it ends. If it's like perfect and is like lining up, it doesn't matter how short or close it is together. But if it is consistent, that's to me is telling me that they're in labor. But they can have Braxton Hicks contractions. So these are contractions that kind of mimic those labor pains. They're still contractions, but they are irregular. They're not sustained. Usually, whenever these are going on, they're not in active labor. And then we have lightning. So that baby moves down and gets ready to be delivered. I've seen patients, whenever this lightning is occurring, it's actually like made like a loud like popping feel for mom, and they like collapsed and was like, my pelvis. But that's what was going on, is that this baby just dropped. So sorry. I'm gonna lose my voice tonight, hopefully at the end here. And then we have the actual contractions. So like I said, you want to time these out, see how long they're lasting and how long in between contractions. So note the time, note the interval, note the frequency. Whenever they're starting to get about 30 seconds to 1 minute long and are about 2 to 3 minutes apart, or even shorter, then that baby's on its way. So what do you think? If you're sitting there and you're like, okay, you kind of time out the first couple contractions and they're a minute apart, what do you think you should check for? Crowning. Yeah. And that is one thing that I have noticed working in like a busy system that went on a lot of pregnancy calls. Nobody wants to check for crowning. So I don't know what it is. If people are just like, I don't want to look at that, so we're just going to drive to the hospital. But there's been a few people that have been caught with their pants down and their patient's pants not down because they're like, oh yeah, no, it's fine. And then they get them in there and the ER pulls off the pants and the baby's like coming out. So make sure, yeah, surprise. Yeah. So amniotic fluid. This is part of our first stage of labor. So that water breaks or that amniotic fluid breaks, the ruptured sac. We want it to be kind of like a clearish color. What does it tell us if that color is like a green or like a dark brown or an icky color or has a smell to it? Meconium staining. And what is meconium staining? Yeah, the baby pooped because it's in distress. So this is kind of the color that you might see with meconium staining. That baby is stressed out for whatever reason during delivery, and that amniotic fluid can become stained. So if you're dealing with a delivery and you notice meconium staining, they used to, back in the day, it used to be protocol that if you saw meconium staining, you intubated that baby like right away and then suctioned. That's not a thing anymore. The biggest thing here is if you have meconium staining, you want to make sure that their mouth is suctioned out really well. If you're hearing any kind of gurgling, you always want to suction what first, the mouth or the nose? The mouth. Why? So whenever they take that first initial breath in, they're going to go, and if they have any goop in their mouth, they're going to suck it in. So mouth, then nose. All right, second stage, here's kind of a diagram, I almost said diaphragm, a diagram of like the stages. So that cervix gets pretty big. Labor pain is severe. If you ever have a patient, please take note. If you ever have a patient that says, I need to poop, and they are pregnant, don't walk them to the toilet. Please. Yes. If they have to poop, it's probably because they're about ready to push that baby out. No, don't let them go to the bathroom. Listen, in the EMS, I've been doing this 10 years. If your patient is like, I'm going to shit, here's the thing. They're either about ready to push a baby out or they're about ready to die. Those are the two things. So they can poop on my stretcher. Yeah, people like right before they die, for some reason, a lot of people right before they die are like, I have to poop. And then they just poop and then they die. I don't know what it
If you
is.
get on scene and that patient's blood pressure is 70/40 and they go, I have to poop before we leave, be like, suck. I don't know what to tell you.
Yeah.
Yeah.
It's just, it's like one of those like unspoken rules of patient care is like if they look like crap and they're like, I have to poop on my stretcher because you're about to die. All right.
Deliver a baby.
So in the second stage of labor, if you get on scene, you're doing your assessment. If delivery is imminent, I would suggest that you stay on scene and deliver the baby. If you move them out to your truck, that's fine. If you can make it out to the truck. If not, and you're like in a kind of controlled environment, living room, whatever, families running around freaking out, give them little jobs to do. I love to have them go put towels in the dryer, go have them boil water, and I need 16 pens exactly. If they're freaking out, I give them weird random jobs, and then you just get ready to deliver the baby. That is up to you though. I wouldn't suggest trying to deliver a baby in the back of a moving ambulance because there's a lot of stuff going on. And if you don't have a lot of hands, it's good to have extra hands. Babies are slippery, so they have a high probability of being dropped anyways. So if you're moving around and you have a slippery little baby, just stay and deliver the baby. All right, so third stage after the baby's birth, these contractions are going to resume and they're going to deliver the placenta and all the afterbirth. So whenever the placenta does come out, I should have put a picture of this in here. I can look it up. There's like little nodules on the placenta. This I don't think has it. Not well. So there's like little nodules on a placenta. So sometimes if you have a second and you have the placenta and the mom's delivered it, make sure you're looking at the placenta because you'll see if one of those nodules is like tore. And sometimes that's still in the mom. And if you notice that, that is something important to tell the ER because they got to go get that out because there is a lot of infection that can go on if any part of the afterbirth is left in mom. Okay? I'll try and find a good picture. All right, so assessing the pregnant patient. Please wear your PPE. You guys all saw a picture of the explosive delivery. I think it's like page 1. It's like one of the first pages. It's a possibility. So goggles, face mask, gown, hairnet, shoe covers, all of it. We carry these little OB kits on the ambulance. They kind of look like this. Some of them can be like in a box. They have a list of all the stuff that's in there. I usually suggest grabbing a couple extra chucks pads, so like absorbent pads, a couple extra blankets, a couple extra sheets on top of this. So there's a picture of all the stuff that's in here. Another thing, you want to keep the back of the ambulance warm. So if you're not sweating, it's not warm enough back there. Your number one priority in delivering the baby, besides the airway breathing stuff, keeping that baby warm. So we want to heat the back of the ambulance. We have little baby heating pads. We have other stuff. I'll show you some pictures.
Do not wrap the baby in paper towels.
Yeah.
And I say that because I have had somebody hand me a delivered baby wrapped in paper towels, and then I had to spend freaking 45 minutes trying to get paper towels off this baby. And then the OB looked at me and her funny, like we were the ones that did it. So don't do that. They're not useful. They don't keep the baby warm, and they just get sticky and stuck to the baby. So don't do that. Towels, the little warming blankets that we have, sheets off the stretcher, whatever you need to do, grab what you need, but just don't use anything that's going to break apart and stick to the baby.
All right, so what are some key questions that you want to ask? If you have time to ask these questions, obviously if someone's in active labor and they're like, hey, F you, shut up, I'm going to shut up and just keep going, right? But if you can ask some questions, what are some questions you think you would want to ask? First pregnancy, contractions, due date, good. Prenatal care, that's a huge one. What else? Yeah, first pregnancy. Allergies? Sure. I mean, good. Total pregnancies, live births. Good. Previous issues or any problems with this pregnancy in particular, both are very important questions to ask. Last menstrual cycle, if you don't know the due date, you can usually ask them that. Sometimes they can give you kind of like a generalized idea. How many pregnancies have you had? That gives you a great indication of how quick that baby's coming. Because if it's like 9th baby for mom, you're like, all right, she's just got to sneeze funny and it's coming out. They just and then has the water broke, mucus plugs, that kind of thing. Any blood, any problems. What is this? Yes. Gravida is how many pregnancies they've had. Para is what? Live births. So I remember this by how many pair of feet on the ground, or how many little paramedics running around. And then abortions. So this is not just initiated abortions. This is also includes your spontaneous abortions. What's another name for spontaneous abortion? Miscarriage. Good. All right. So EMTs do not deliver babies. Mothers do. We're just assisting the mom. So moms, humans, have been having babies for hundreds of years, thousands of years. So their bodies, for the most part, know what to do. You're just there to assist, right? Expecting some like problems is always a good thing because we like to prepare for the worst but hope for the best. So your primary role is to determine whether you're going to be delivering that baby on scene or if you can make it to the hospital. Like I said, if you look and that baby's little head's like, hey, what's up? It's probably best to stay. Yeah. So preparation, you want to try and control the scene. Like I said, family members like to get super excited. If you have anyone that's acting like freaking, what's his name? Ace Ventura, when he's like, I like to give them a job to do. This is helpful in any situation, really. I've had like partners that kind of are like bugging out a little bit, and I just give them like a weird random job, and it helps. PPE, again, we're going to keep saying it. Place mother on the bed, floor, or stretcher, whatever is available at that time. Remove the clothing obstructing the vagina. Sometimes they want their shirts off too, because there's been a lot of studies that skin to skin immediately after delivery is beneficial for the baby. So sometimes they just want their shirt off anyway, and that's fine. We have like these little gowns in the back of the ambulance you can lay over mom. And then grab your OB kit. I like to grab 2 OB kits just in case there's something missing from the first one, or if there's multiple deliveries that I don't know about. It's always good to just have an extra one. And then make sure the environment is warm. So we want to keep baby warm. If mom starts bleeding out and we're treating her for shock, we want to keep her warm, so you kind of get a twofer there. Here's that OB kit. This is generally what's inside most of them. Here's your little clips. Maybe I don't see a picture of them.
Yeah, that's them right there.
Oh, there they are.
These little clips right here are for the umbilical cord.
Yeah.
I'm pretty sure this is like their little stocking hat thing that you're supposed to put on them
Don't clip it.
right
'cause you
after
won't be able to
delivery.
get it undone.
Your little scissors, gloves, pads.
Pass it. I'm gonna toss these back to you. Huh. Not bad. I was never a golfer. So there's a little hat in here. You want to keep that baby warm. What happens if you don't have those little clips? What can you use instead? Shoelace, yeah. So if you have a clean shoelace, you can use that to tie off the umbilical cord. Do what you gotta do, MacGyver some stuff. Usually there's another extra little bag in there for the placenta. So if mom has delivered the placenta and the cord's been cut, keep that placenta in a bag and take it with you to the hospital. All right, so whenever you're assisting a delivery, my favorite thing to do is I like to take, I don't think there's even any in here. I take a sheet and I lay it up under mom's butt and I put some Chuck's pads and then I roll it. So as the mom's starting to deliver and there's juices and stuff coming out, all I got to do is grab that sheet and roll it into itself. So it kind of keeps everything contained, right? So I'm like sitting right here. Mom's here. I'm sitting right here. We're ready for this delivery, right? If you have 2 providers, keep one at the mom's head. If dad's not there or if other family members aren't there, emotional support's a big thing. So that's huge. Make sure you're communicating with the patient. And then, yeah, that's it for that slide. This is just a quick little delivery video. So this is a good like view of kind of what you should be expecting.
This is a simulation model that we use to practice simulations of vaginal births. We use these models to practice and to help train others. Here you can see the baby's head starting to crown. We place our hands on the perineum, which is the area between the vulva and the anus that stretches for extra support. We also have fingers on the baby's head to help them ensure that it delivers in a controlled way and doesn't just come out too quickly. Once the baby's head is out, we guide it down while mom's pushing so the top shoulder can come under the pubic bone. Once that's delivered, we guide the baby up so the bottom shoulder and the rest of the baby can deliver. And there you have it. Happy birthday, baby. Hope you enjoyed watching that simulation.
I don't know if I enjoyed it, but it was.
That's really enjoyable.
Yeah. Huh? So it kind of does it on its own. Like as the baby's delivering, it'll come out and then start to like twist on its own. So you're there to support it. So also you're supporting that perineum. So you're bringing your hand up under too, because you don't want it. You're trying to prevent like ripping of the vagina, right? So your hand's like at the bottom to support it, and then you're guiding the baby's head out with another hand, not like holding it in or reaching in there and trying to pull it out, but you're guiding it because if it does like want to have an explosive delivery, you don't want it to be like out too quickly. So those are some things that you want to keep. If the baby's head comes out and you see the cord wrapped around the baby's neck, try and fit a finger up under that cord and slide it up over the head. Sometimes it's going to be too tight for you to do that, but a lot of times all you got to do is just find it and slip it up over the head. That's what happened to me my first delivery. I just seen the cord there, bloop, it went right over the baby's head, and then she just delivered just fine. Make sure you note the exact time of birth. So our monitors have little things that you can timestamp things. I timestamp something random, but it's the time of birth. And then now you have 2 patients. So you still have to take care of mom. You still have to take care of baby. There's 2 charts. So as much as that sucks, that's one thing you don't want to do. That's also the crappy part about delivering a baby. You're like, dang, I got 2 charts now.
But to go off what you were saying, if the baby, for whatever reason, isn't turning like it's supposed to, if it's getting stuck, you're there for support and to try to assist mom. Don't crank on baby's neck to try to get it to turn. Don't pull on baby's neck. If you want to know how that ends, ask the Southern Regional doctor that decapitated the baby. So I do, again, we are assisting mother in delivering this baby. We are not trying to forcefully deliver this baby for mother. So whatever the baby's doing, you're just there for support. You're not there to force the issue. And if it gets stuck, drive faster.
Mm-hmm.
Like that's the best advice I can give you.
Does anybody know what it's called whenever that shoulder gets stuck? Yeah. So that is probably, when I think of like OB calls and I think of like the scariest, shoulder dystocia is the scariest. So what happens is that shoulder gets stuck on mom's pelvic bone, and there's a couple maneuvers. There's a video coming up that'll kind of show you some maneuvers to get out of it. But it's like one of those things that when it happens in the ER, there's like a lot of things that happen really fast. They try this, they flip mom, they try this, that don't work, immediately to the C-section. And that's actually how that baby got decapitated, because its head was still stuck. Doctor pulled baby's head off, and then they tried covering it up, so it turned into a whole thing. Yeah, it was gnarly. Yeah. Well, so what happened was she delivered. They're like, hey, your baby didn't make it. They brought her baby in to hold it like one more time, and they had wrapped it in a blanket so it looked like the head was still on it. And then they were like, oh, you don't need an autopsy for this. Just like go get it cremated. And she's like, no, we're going to get an autopsy. And they were like, yeah, this baby's head came off. So they got in trouble for trying to cover it up. That's Southern Regional for you, though.
Yep.
So neonate, assess the neonate immediately after birth. You guys were talking about it earlier. What score do we use to assess a neonate? APGAR. This APGAR score is done at 1 and 5 minutes. So if you memorize the APGAR score, that is awesome for you. I love that. I suggest having like an app on your phone or a little badge buddy for the APGAR scores, because in the moment, me personally, I'm like, what's 5 again? I don't remember any of it. So this is what you're looking for. So appearance, if normally when they're first born, if their APGAR score isn't very high at all. So normally they're kind of here in this like 1 range. So whenever that baby's born, you're going to try and stimulate the baby. You're going to dry it off real good, not with a paper towel. You're going to tap the bottom of its feet. You're going to suction mouth and nose, and you're going to kind of rub on the baby. And that stimulates it to start breathing and for everything to start moving around. So usually your first score is somewhere in here, sometimes in here, and then your 5-minute, it should be higher. So as you're assessing the baby, you're looking at the color. Are their hands blue? Is there a central blue? Are they crying? Are they kind of weak crying? Are they just grimacing? Are they kind of moving? Are they moving a lot? Do they have a strong cry? These are all things that you're trying to take note of. And if you're down here, this is where you need to start your resuscitation. So does anybody remember what our resuscitation is, what we should first start out with a little tiny wee babe? 3 to 1. Yep. What if what if their heart rate's 82 and they're not breathing well? What are you going to do? Not blow by. You're going to ventilate them. So you're going to give them oxygen. At what point do you start CPR on a neonate?
Under 60.
Under 60. Good. What age is a baby considered a neonate? 28 days. 28 days. I know everyone's like 30 because it's easy to remember, but it's 28. So even if you get called to a residence with a newborn, that newborn's a week old, you're still going to act like you would with like the first delivery of a baby when you're resuscitating. All right, little space baby. So keep the baby warm, stimulate the baby, tap its little feet, dry it off. You're trying to stimulate the baby. Get rid of the wet blankets, the bloody blankets, because wet makes baby cold. So you want them in fresh, new blankets. Sometimes you have this little space blanket on an ambulance. We have them for adults too. Kind of helps hold their little heat in. Make sure that their head is covered. We have those little beanies. And then encourage breastfeeding. Does anybody know why we encourage breastfeeding?
Because it's better for the baby.
It initiates contractions.
Good. Yep. It initiates contractions. So why is that important? Yeah. Helps deliver the placenta, and it helps stop any like postpartum bleeding that may be occurring. So the umbilical cord, like we said, a lot of times now we wait for that pulsing to stop before we cut that umbilical cord. That can be dependent on mom. If that baby needs resuscitated right away, like not breathing, no pulse, we're going to cut it and get to work on the baby. But if we have time, we have a happy, healthy baby, you got a little bit of time for it to sit there and pulse. It doesn't take very long. You can feel it, you'll see it. The umbilical cord will actually like pulse, and then it'll slow down and stop. Once the baby's delivered and they're still connected to the umbilical cord, don't hold the baby like way up here above mom. Does anybody know why?
Because all the nutrients is like just going back down.
Yeah, exactly. So the baby's up here, the umbilical cord's still connected, and it's all going to start flowing back down. So that can affect their red blood cell count. So try and keep the baby at the level of the mom or like directly onto the mom's chest. That's something that you can do as well. Yeah, this says if protocol requires it. If I have a mom that's like, wait, like delayed cord clamping, I'm not going to be like, my protocol is to cut it right away. I'm never going to do that. All right, so use sterile clamps. We have those little clamps in the OB kit. If you don't have those, you can use like a clean shoelace or something like that. One clamp about 10 inches from the baby. If you have that much room, so like I said, sometimes those umbilical cords aren't very long. If you have enough room, 10 inches. If not, just use your best judgment. You do want a good amount of umbilical cord away from the baby. Does anybody know why? Well, yeah, we don't want to cut the baby. That's a bad day for everybody. Eat the baby. All right, so we have our umbilical cord here. We want our first clamp up kind of high, right, away from the baby. If that baby needs any kind of resuscitation whenever it gets to the hospital, what they end up doing is they actually cut where you clamped it, and they can get IV access into the umbilical cord. But if there's not enough umbilical cord, you can't do your IV access there. So clamp from the baby, a second clamp, cut in between the two. Be careful when moving the baby. Babies are slippery whenever they first come out. There's a lot of stuff on them. So be careful. Like I said, don't hold it way up high above mom. Keep it at mom's level or on mom's chest. That's going to be the ideal spot for that baby. And then after this, you're going to encourage mom to breastfeed. So here's an example picture. 7-3 cut in between. So dry, warm, stimulate the baby for about 30 seconds. That should be your first step. You're sucking out the mouth, you're warming them up, you're stimulating them. Establish that that baby is breathing. If they are not breathing, or if it's shallow, slow, or gasping, so you want to provide positive pressure ventilation. This is 1 breath every 3 seconds. So 1 and 2 and 3 and breathe. And 1 and 2 and 3 and breathe. That's the best way to remember any kind of neonate resuscitation. At this point, you're going to assess the heart rate. Where do you check for a heart rate on a newborn? The brachial pulse, right? Another way that you can do it, that's actually easier because little babies' hearts beat fast, right? So we're looking at like 150-ish, 160. That's really fast for you to sit here and be like, 1, 2, 3, 4, 5, 6, 7. That's so fast. So one thing that you can do, if you have a partner or an extra set of hands, you can actually take a stethoscope, listen to the baby's heart, and tap your finger with the baby's heartbeat, and then have your partner count your taps. And then from there you can divide it or times it or whatever you're going to do. So if the heart rate is less than 100, you're going to continue to ventilate baby. That's the number one thing that's going to cause a low heart rate in a baby, unless they have a weird congenital disorder. So you're going to assess if it's less than 100, ventilate baby. If it's less than 60, you're going to start CPR on the baby. So 3-to-1 ratio, same thing. 1 and 2 and 3 and breathe. And 1 and 2 and 3 and breathe. So you're going to do the 2 hands around the baby. I have a picture here. You're going to have 2 hands around the baby, and 1 and 2 and 3 and breathe. And 1 and 2 and 3, and you have someone there breathing. Whenever you're ventilating a neonate, what are you looking for with your ventilations? Equal chest rise and fall, right? What's the best way to open a neonate's airway? Pad behind the shoulders, perfect, because their heads are ginormous. Look at that thing. It's like a baked bean. So pad behind the shoulders, good seal, little tiny breaths. For these guys, itty breaths, okay? If their pulse and respirations are adequate, you can just move to routine care. So continue drying the baby, suction mouth and nose, keep the baby warm, put baby on mom's chest. This is like that upside down triangle of neonatal resuscitation. So whenever we're looking at resuscitation for an adult, we're like, oh, CPR, airway, drugs, right? You shouldn't get to drugs. That should be the very last thing that you should do if you're trying to do any kind of neonatal resuscitation. So most of the time, they come around after the drying, warming, and stimulation. If that's not working, you start the oxygenation. Remember, for kids, hypoxia is what's causing that low heart rate. If those two aren't working, that's whenever you move to your advanced airway. So you shouldn't be thinking of like more ALS-y things until you've tried all of the BLS things, right? So after delivery, you're going to assess the mom, make sure you're checking vitals, you're checking oxygen saturations, you're making sure mom's still alert. So the very first delivery I had, mom actually passed out on me from blood loss. And it was probably a good thing that I was with a very advanced paramedic. That she was like, had been doing this forever. And so she was taking care of the baby, and I'm stuck with mom that's like passed out on a bathroom floor. And I was like, this is awesome. So make sure you're assessing the mom. Make sure you're checking for copious amounts of bleeding, right? If she's awake, talky, all that stuff, you're going to start the breastfeeding thing. There's also this thing called an amniotic embolus. So if that's happening so normally what happens is they get like a sudden onset chest pain, shortness of breath during the delivery or shortly thereafter. That is not something we can fix in the field, even as an ALS provider. They need an emergency room, like 2 seconds ago. Make sure you're checking the vital signs. Deliver the afterbirth, like we said, it might take up to 30 minutes. So sometimes that's a thing that you're like, all right, let's get going. And then they don't deliver it till you get to the ER. Sometimes it comes sooner. They're still having contractions during that period. So that little placenta is still sitting in there. Please, for the love of God, they're like, do not grab and be like, oh, it's taking too long, and then just yank. Please don't do that. Ew. So how are we going to control vaginal bleeding if it comes down to it? Fundal massage, dry sterile dressing. Do not pack the vagina. Please don't shove a fist up there and be like, I'm stopping this. That's like not in our realm at all.
Where's Mike at?
Where's Mike? Yeah. So replace blood sheets and blankets. This is that fundal massage that Miss Amanda was talking about just a second ago. So to do this, mom's bleeding is not a good time for mom. You're trying to slow that bleeding, right? You're having them breastfeed. What you're going to do. Perfect. I'm going to stand right here. So you're going to support the bottom of the fundus. Can everybody see that? Okay, and then you're going to take your fist and you're going to massage. So sometimes you can use an open hand. You can feel that uterus up underneath your hand, and you can actually feel it contracting while you're doing this. This is not comfortable for mom. Like you're digging a fist into mom's belly that she just shoved a baby out of. It's not comfy, right? But if she's like bleeding a lot, this is something that you need to do to help contract that uterus and then stop that bleeding. It's not comfy. You can also place a napkin. That's not going to stop the internal bleeding, obviously. That's going to kind of just control it. All right, so this is kind of a long video. No, it's not. There's another video coming up that's kind of long. This is just an example of that fundal massage or uterine massage, whatever you want to call it.
To perform external uterine massage, first the lower hand is placed in a cupped position over the lower uterine segment just above pubic symphysis. The upper hand is then placed at the uterine fundus, thereby positioning the uterus between the examiner's hands. The uterine fundus is then massaged gently in a rotating fashion with the upper hand, while the lower uterine segment of the uterus is supported by the lower hand. Upon massage, the uterine muscle is expected to contract and will start to feel very firm. After uterine massage, once again examine the perineum for bleeding and clots that may have been expelled.
Yeah, so sometimes while you're doing that, things are going to like go out. So whatever other tissues might be stuck up in there, you're helping get them out. Yeah, I've had to do it once, and mom was screaming at me, and for good reason. I'm like, yes, scream at me, please. So some common complications of childbirth. The most common one is cord around the baby's neck. Like I said, if you can take it and slip it and slide it up over the head, that's awesome. If you cannot, try and get that baby delivered as much as you can. Get some of that pressure off the cord, and you might have to cut the cord and unwrap it. Another one you might run into is an unbroken amniotic sac. This is also called I believe an on-canal birth is what they call it.
We have a special guest speaker for y'all today.
Oh, good. Let me go back.
All right.
Oh, here.
Today class, we're going to talk about what not to do.
Okay. So believe it or not, I was once upon a time an EMT student. Okay? I know, it seems far-fetched. I was running with a paramedic. I was doing my ride-along time at Elko County Ambulance. Prior to doing my ride-along time, I was in a class that taught us how to stop vaginal bleeding. We were taught a very specific method. So I go on my ride a long time. I'm a brand new EMT. I'm like so freaking stoked and cool, right? I'm here riding with Elko County, this super sweet paramedic. And we're going through, she's popping out the drugs. Her name is Brittany Hoover. I ended up running with her husband for like 2 years here, one of my best friends in the world, super talented. And she was a good medic in her own right. And we're like popping these drugs, and she's like, well, what does this do and this do? And I'm like, dude, I'm a grade A student, right? Like I'm the hottest shit on the block, no doubt. I got the answers to everything. And she knocks open Pitocin. So for you guys that are learning, Pitocin is a natural hormone that is excreted by the body to help stop bleeding, right? It helps contract. So she's like, oh, what's Pitocin? I'm like, well, I know what that is, and I know what it does. And so I'm like, and to preface how freaking cool I am, if a lady is hemorrhaging out of her vagina, I know what to do. She kind of puts it down. She goes, what are you going to do? I said, all right, no worries. I got you. I'm going to take my right fist. Shut up. Quit laughing. This is a true story. No embellishment. I'm not fucking kidding. I said, I'm going to take my right fist and I'm going to shove it up the vagina. And then I said, I'm going to take my left fist and I'm going to clamp it over the abdomen. And I'm going to create a clamp in there so that we stop the bleeding. Right? I'm like, fuck yeah, look at me, dude. Yeah. And so she stops. She kind of puts the drugs down. She goes like this. She does this number. She looks at me. 7 seconds go by. No one's saying anything. And I'm like, dude, I just wowed this lady. Like, she thinks I'm the coolest shit in the world. She literally doesn't say anything. She gets up, gets out of the truck, goes inside. And I'm like, where'd she go, dude? What's going on, dude? About 5 minutes later, she comes back outside. She sits in the truck. She sits down and she goes, okay, I feel like we need to clear the air. You will never, as long as you're running on one of my ambulances, ever even remotely consider shoving your fist in a lady's vagina. And I'm like, what? Never. You will never shove any of your appendages inside of a lady's vagina in this ambulance. Are we clear? Yes, ma'am. Yes, ma'am. Right. We go on about our day. Everything's like not the greatest, right? But nonetheless, we're going about our day. Thank God we didn't have any ladies that gave birth. Several years later, I'm sitting here in Lander County EMS with my new partner, Mike Hoover, who's an absolute stud. Like, the dude is as gangster as they come. And he proceeds to tell me a story about a dumb fucking EMT that wanted to shove his fist in a lady's vagina. And you know what I told Mike Hoover? Damn, that sounds dumb. I can't believe that. They did what? Nah, dude, that's crazy. I couldn't believe it. But listen, I'm gonna tell you this because I wasn't the only one. We had a lady who was crazy as shit teaching at the time, and that's what she taught us. So they had 5 other EMT students come behind me that said the same thing. So they had to call the college. The college had to bring us all into a room. The professor, like the head dog in charge, had to come in with the dean and say, guys, you're not doing that. You can't do that. You're not shoving anything in ladies' vaginas. Please. And stop laughing when you say the word vagina. Grow up. You know what I mean? So it wasn't all my fault, but partially my fault. Anyways, I'm the one that stemmed the phone call all the way to the dean of health sciences at Great Basin College at one point. I ended up coming clean to Mike. I'm like, yeah, bro, that was me. I was actually taught that. I'm going to preface this by saying, while you ride on our ambulances, you will never shove your fist in a lady's vagina. Are we good?
Would that even work?
I don't know, bro. I was taught it. I don't know. Well, in theory, dude, like, it makes sense, like direct pressure, like, you know, you do a fundus massage if they're bleeding, but man, I didn't know any better. Shit.
Long story short, when's the only time you use your fingers around somebody's vagina?
Check.
Prolapse cord. Yes.
It's back in the ambulance. I guess I should have been more specific.
Yeah. It happens. All right.
That's why if
Where were we?
anybody ever tells you something that's like, that sounds a little strange, probably should ask somebody else just to make
Yeah.
sure.
It kind of turns into like sexual assault charges at that point, I feel like.
Yeah, yeah.
Don't do that. All right, so unbroken amniotic sac. If you run into this, break the amniotic sac. Just don't stab it with nothing. Just grab it, twist it with your fingers. It'll break. And then infants who need encouragement to breathe. So these are the most common things you might run into. I think the numbers are like 10% of deliveries actually ever have complications. So the chances of you running into something like this is pretty slim, but it's good to know, right? Because we want to prepare for the worst and hope for the best. This is an abnormal delivery, a breech presentation. Of the abnormal deliveries, this is the most common. So here's your little breech. Sometimes just their little foot comes out. Sometimes their butt comes out first. And then the frank, their little legs are like way up over their head. So risk of birth trauma to the baby's high. There's a video coming up of a breech birth. So you'll see the baby pooping while it's going on because that baby is in distress. I'm not going to lie to y'all. I've never ran into this. And if I do, I'm going to be pooping my pants the whole time. So this is the one that's kind of long. That's not what I wanted. Please work.
It's working.
Delivery, and the mother at increased risk of cesarean.
He's trying to flip the baby around.
Reduced
That's great.
C-section or
There's a
vaginal breech
C-section.
delivery.
These are barbaric as well.
Planned cesarean section prevents about 1 perinatal death for every 100 deliveries.
This video is a little outdated, but
The risks to the baby of vaginal birth are outweighed by the current and future risks to the mother of cesarean section. Or cesarean section is not feasible. It is thus important for health workers who care for women in labour to be skilled in breech delivery techniques. Favorable factors for vaginal breech delivery are shown here. If labour does not progress well or the buttocks do not deliver easily, it is preferable to opt for cesarean section. The techniques of vaginal breech delivery shown in this program have evolved from clinical experience, not randomized trials. The delivery position used in the cases which follow is with the mother sitting propped up at 45 degrees with a backrest, or resting on the thighs of an assistant kneeling on the bed, and her legs in lithotomy stirrups. She has an intravenous infusion in place, and her bladder has been emptied. An assistant encourages her to bear down effectively. It is most important that the baby be expelled by effective bearing down efforts. Any traction from below tends to cause an extension of the arms and head, and the episiotomy may be cut as the buttocks descend the perineum. Only after the buttocks have delivered
legs.
easily and spontaneously, and the decision is taken to continue with the vaginal delivery, commence an oxytocin infusion to assist uterine contraction. As long as the delivery progresses spontaneously, resist the temptation to pull the baby down, up to the point that the shoulders have delivered. Once the baby's head is engaged in the pelvis and the hairline is visible, control the delivery of the head with a method such as the Morris-Smelly bite method. With the baby straddling your right forearm, position the third finger in the baby's mouth and the second and fourth fingers on the nasal bones. Place the second and fourth fingers of the left hand over the shoulders and the third finger against the occiput to maintain flexion while the head is carefully delivered. The second breech delivery shown here is more complicated. The extension of one of the baby's legs is a favorable factor. In the case of a frank breech presentation, splinting of the baby's body by both legs may prevent progress. In such a case, deliver the legs by gently flexing at the knees.
see him pooping?
When the umbilical cord appears, pull down a small loop to prevent traction on the cord later in the delivery. The baby's back will usually rotate anteriorly. If it is tending to rotate posteriorly, Hold the baby with a towel around the pelvis, not shown here, and gently turn the baby so that the back faces anteriorly. If the shoulders do not deliver spontaneously, despite effective bearing down efforts, their delivery may be assisted by various maneuvers. The anterior arm may be delivered by passing 2 fingers over the baby's back, along the humerus to the elbow, and sweeping the arm around in front of the baby's face and chest. One or both of the shoulders may be delivered by the Lcems maneuver. Hold the baby by the pelvis with a towel, not shown here. Rotate the baby through 180 degrees back uppermost, so that the posterior shoulder appears below the symphysis pubis to be swept down over the baby's face and chest. If the baby cannot be rotated, the posterior shoulder may be delivered by lifting the baby upward, chest towards the mother's thigh, passing 2 fingers up the baby's back, and sweeping the posterior arm over the baby's face and chest. Once the arms are delivered, encourage the mother to bear down until the baby's neck and hairline appear.
I like how you're just standing there like, I'd be like,
If the head is not engaged, the horizontal right method may be used to push the head up slightly, rotate the oblique diameter, flex it, and pull down. Suprapubic pressure may be used to assist flexion and descent of the head. Here, the baby's head is delivered by Morris's semi-bite method, as described before, and assistance may support the perineum. The second breech delivery shown, though difficult, took 4 minutes, and the baby was in excellent condition after birth.
now he's
An
just
alternative
chilling.
method of delivering a head is the Burns-Marshall method. Once the head is engaged and the hairline is visible, hold the baby by the ankles with your left hand and swing the baby through an arc up to a vertical position and then
Somersault
over
the
the
baby.
mother's abdomen. Support the perineum with your right hand as the face delivers. For forceps delivery, hold the baby by
We're
the
just gonna
ankles
skip
and
this.
swing to the 45-degree or vertical position.
They don't
Oh.
do forceps delivery no more.
Want to do the handstand?
No, the forceps, they come in with the forceps.
Ah,
All right,
that
so
baby was doing a
you
handstand.
can see how the different presentations. Am I going to expect you to remember all of that? Probably not. But it kind of shows you it's a good idea to know the anatomy of what's going on. So if you are having any kind of difficulties, you can kind of see how it should be done. Because if we're way out here in BFE Battle Mountain and we're delivering a breech baby, you don't have time to get to the hospital for these kind of things. So certain maneuvers, keeping mom's head down is what they suggest now. Like in the video you saw, they keep mom's head up. Make sure that you're giving high flow oxygen to mom. She's going to be in distress just as well as this baby's going to be. And be prepared to resuscitate the neonate if you run into something like this. All right, so limb presentation. Usually it's commonly a foot. A little foot comes out. The best bet is to transport to not deliver the baby. If there's anything I have learned in doing this for 10 years, you're not stopping no delivery of a baby. That baby's coming. So drive fast. Don't be like, hey, we're going to stay on scene and deliver this baby. That's the point that they're trying to get across. If you're like, okay, we're delivering the baby in the house, and then all of a sudden this little foot's popping out at you, it's time to get moving. So do not pull on it. Do not put it back in. Like I said, this is not something that we can stop or slow down. Like, excuse me, not today. You need to cook a little longer. No. Prolapse cord. Do not place gloved hand into the vagina unless there is a prolapse cord. This is your one get out of jail free time. So when that cord comes out, first, they say to wrap the cord if you have a moist dressing. So that cord's coming out. The baby's head's pushing on the cord in the little pelvic. So what you can do is kind of put your fingers in and keep pressure off of that cord because that's what's delivering that baby oxygen and nutrients, right? So you can come in and kind of keep that pressure off of the cord as it's trying to deliver. This is another thing that if you see that cord popping out, it's no longer time to deliver that baby in the house. We're going to start moving. All right. Care of a prolapse cord. Sometimes you can have the mom flip to kind of keep that pressure off of it as well, in like a head down position. High flow oxygen. Check that cord for pulses. Like I said, you can see whenever that cord is pulsating or not. So if the baby's still in the vaginal canal and is still trying to be born, we want that cord to have a pulse, right? Because that's how that baby's getting all of its oxygen and nutrients. If you can find where that pressure is on the cord, try and relieve the pressure and transport immediately. Multiple births. So your best bet for this, yeah, hey God, me again. If they know they're having multiple births, obviously this is something you can prepare for. Sometimes you don't know this. So working in big cities, places like Atlanta, we ran into a lot where they don't do pre-hospital care. So keep in mind that that's also a possibility. They may not know that they have multiple deliveries. They may not know when their due date is. They may have had no prenatal care. So these are the patients that you're like, well, crap, like we could run into anything here because we don't know anything about this pregnancy. So same kind of route, placenta, baby gets born, placenta, baby gets born. You're just doing it twice. So in theory, right? So keep babies and mom warm. Make sure you cut or clamp the cord off the first baby in time for the second baby to get delivered.
And now you have 3 charts.
And now you have 3 charts. Yeah, dang it. Premature births. So per NRP, it is 21 weeks. So if they're 21 weeks along and they need resuscitation, that's whenever we work the baby. If they're younger than 21 weeks, the viability of that fetus is not there. So if we don't know and they're kind of like in that where they're getting, so usually if they're delivered and they're around 21 weeks, they're very hairy. They don't get this like white covering. So whenever you deliver a baby that's full term, they get like this white cottage cheese stuff on them. It's called the vernix caseosa. And that's telling you that that baby's full term. So anything before that, they don't get that vernix caseosa. Usually they're very hairy. They're like fuzzy little babies. So that kind of, if you don't know how far along the mom is, those are some things that you can look at to be like, okay, this is a premature birth or not. So keep the baby warm. That's going to be a hard thing to do because this baby's so little, teeny tiny. So it's hard to keep these babies warm. They have a lot more surface area in comparison to their body mass. Watch the umbilical cord for bleeding, avoid contamination. So another thing you might run into that I didn't see it in y'all's book, it might be in there, correct me if I'm wrong. Sometimes their organs are also they're born with their organs on the outside of their body. Does anybody know what that's called? There's a fancy name for it. It's called an omphocyele, I think is how you say it. Yeah, so if there's any point where you're delivering a baby and the organs are on the outside, that's one of those things you want to wrap it in like a warm, moist, don't like boil water and then wrap them, but try and keep that water, don't like grab it from the fridge. A moist, sterile dressing, put it on the baby's organs, wrap them, keep them warm, and then transport. All right, so meconium staining we talked about. This is whenever that fetus is in distress. They poop inside their little amniotic sac. So this is telling you that that baby was in distress for whatever reason prior to birth. Like I said, back in the day, we used to be very aggressive about the airways of these babies. These days, the studies that I've read, they're saying that don't be so aggressive about your airway management. Just make sure you're suctioning that mouth out really well. And then the nose, if you hear any kind of gurgling while the baby's trying to start cry, you need to suction some more. And just in case, I'm pretty sure, I'm just going to say this. We don't use the suction that's on the wall in the ambulance, okay? This is the suction that we use for the wee babes. So squeeze, put in the nose, let go, blow it out, okay? Our suction that's on the wall is too much pressure for a wee babe, and you can cause more damage. So, or cause damage, not more damage, just damage. All right, excessive pre-birth bleeding. So there's a few complications that can arise from a pregnancy that can cause pre-birth bleeding. So whenever you're assessing these patients, you need to make sure that you're asking how much blood. Sometimes you can see the blood. Sometimes you get called because there was a little bit of pink on their underwear. If they're going through pads, it's important to note how many pads they've gone through a day, or within the hour, or just anything like that. So those are questions that you want to ask. So one condition is called placenta previa. So what happens in placenta previa, the placenta blocks the birth canal. So here's your little placenta, and here's the birth canal. And it'll actually, like usually it's supposed to be up here on the side of the uterus, and it'll cover. And sometimes it covers just a little bit, sometimes it covers all the way. And usually they know, if they've had prenatal care, they know that this is going to be a problem. So they can kind of warn you about it, sometimes not. So what happens is whenever that baby starts to get bigger and move around, that placenta can be damaged or torn, and bleeding can occur. So usually with a placenta previa patient, the mom is actually not in any pain at all, but there's a lot of like bright red blood bleeding. This is what it looks like, that little placenta. Sometimes it can be fully covering that opening. Sometimes it's just a little bit. And usually if it's just a little bit, they'll know. They can do their little scans and they know beforehand. So this is actually a call that I ran of a placenta previa. The mom was shopping and she got in her car, got out, and she's like, oh, there's blood. So she like walked inside, stood in the shower, and called us. So this is just the blood from her being in her car here. This trail went all the way inside of her house, all the way into her bathroom, and then she was standing there just pouring blood in the shower. And she's like, I'm not even in pain, but there's something wrong. I'm like, yes, there is. Let's drive really fast. So these patients need to go quickly, right? That placenta is providing nutrients and everything to that baby. So if there's any kind of tearing, damage, blood loss, that's going to cause problems for both mom and baby. And then there's abruptio placenta. So an abruption of the placenta. So this is usually caused by trauma. It can happen, not very commonly, just randomly, but 9.5 times out of 10, it's from trauma. So what happens is this placenta starts to come off of the wall prematurely, and they can either be actively bleeding, or sometimes they cannot. So usually this is very painful for mom. This is something that's like they could have blood, they could not have blood. You need to have a high index of suspicion. If you go out on a car accident, this is part of the reason why pregnant patients greater than like 21, 22 weeks are a higher category in our trauma priority scales, because stuff like this can happen. So a lot of pain, sometimes there's bleeding, sometimes there's not. Our ectopic pregnancies, acute abdominal pain. What is acute abdominal? What does that mean, acute? Yeah, it just started. Like, yep, my belly started hurting. Vaginal bleeding may or may not be present. Rapid weak pulse, if they've lost a lot of blood, if they've ruptured, they're going to go into what kind of shock? Hypovolemic. Hypotension. The absent menstrual period is hit or miss for this. So sometimes if it's early enough in their pregnancy, they don't even know they're pregnant, and this is something that can happen. So that's a hit or miss thing too. Don't rely on the absent menstrual period or them even knowing that they're pregnant. All right, preeclampsia. So this is what we see pre-hospitally. If you have a patient that has this and they don't know that they have it yet, your signs and symptoms are going to be the high blood pressure is the biggest one. So systolic, usually this is dependent on protocols, but everything I've learned, systolic greater than 140 and diastolic greater than either 90 or 100. So both numbers are higher, consistently higher. Another thing that is important to know about preeclampsia and eclampsia is this can happen after the baby is born. So they might be like preeclamptic while they're pregnant, and then they start having seizures 2 weeks after they have already delivered the baby. They're still in this time frame where they can be preeclamptic or eclamptic. They don't really know exactly what causes preeclampsia. They think it's like a defect with the placenta that causes it. Some other signs and symptoms that you're going to see, usually right upper quadrant abdominal pain, but any kind of abdominal pain in general. They get swelling, rapid weight gain, like we're talking like 4 to 6 pounds, like it within a week, like quick weight gain, swelling. They might get weird like vision changes. They might get weird sparklies in their vision. They might get dizziness. They might get like a weird aura. So if you have any 2 of these symptoms, especially that blood pressure, this should be very high on your index of like suspicion scale. I love that word. So you're welcome. So preeclampsia turns into eclampsia as soon as they have that seizure. So we cannot diagnose preeclampsia in the field. They can have all the signs and symptoms. We can suspect that it's preeclampsia, but really to rule it out, they have to go get their urine samples. They get high like protein amounts in their urine. But once they are eclamptic, this is that seizure or it's like sudden coma kind of thing. So one of the 2 is now considered eclampsia. If they have had it in the past, they're prone to have it again with another pregnancy. So that's why it's important to ask questions like any problems with past pregnancies. So yeah. Miscarriage and abortion. So like we said, this could be spontaneous or induced. Sometimes their bleeding can be moderate to severe. If they're showing signs of hypotension and hypovolemic shock, you need to treat them for hypotension and hypovolemic shock. They can be bleeding out. Another thing is if they've had a miscarriage or an abortion and that fetus hasn't expelled and all those tissues haven't expelled all the way, they need to go in and get that cleaned out of their uterus because those tissues and everything can sit in there and cause sepsis. So that's another thing to keep in mind if you've had a patient that's had a recent abortion or miscarriage, that if they're showing signs of sepsis, that could be what's going on. All right, and then trauma and pregnancy. So these can be a little bit tricky as well because pregnant ladies, their pulse sits a little higher than usual. So you're going to see the tachycardia and be like, shock, they're in shock. But sometimes that's just normal for them because their physiology of whatever's going on. Blood loss might be 30 to 35% before you start to see any major signs or symptoms. That's a significant amount. Does anybody remember what percentage it takes to send us into shock usually? It was on our bleeding control. It's about 20%. So a little bit higher, right? Ask the patient if she received blows to the abdomen, if she's wearing a seatbelt the wrong way, if she got hit, if she fell into her belly. Like we said, because of that proportion of mass that's different, a little bit clumsier, more susceptible to trauma, falls, that kind of stuff. What is this here? Yeah, this is a uterine rupture. So this is caused by trauma. Sometimes it can happen if they've had like a past cesarean and that scar tissue. I think the incidence of that happening is pretty low. So usually it's traumatic. If you are dealing with something like this, whenever you feel mom's belly, it's going to be very, very painful for mom. And you might feel like bits of the baby. So you might feel like the foot or like an arm or part of the head because that uterus is no longer there. You're going to feel like definitive outlines of the baby. And then cardiac arrest, we touched on a little bit. So you're still going to treat them the 30 to 2. Remember that in the cardiac arrest for a pregnant patient, you are also trying to save the baby because there's a chance that if they get into the ER and mom's not going to make it, they will cut that baby out and resuscitate the baby. And that baby can have a chance to survive. So even if you're like, hey, mom's gone, still do that CPR until you get to the hospital. This is one of those, like, we need to work. Unless it's been like if mom's in rigor or has lividity, those kind of things, like obvious signs of death. Obviously that baby's not gonna make it no more. But if it's like witnessed or whatever, if you're within that 20-minute, you're gonna start working them on. Hands go a little bit higher on the sternum just because everything gets pushed up. So even that heart is going to get pushed up. So hands are going to go a little bit higher on the sternum, and then you can manually displace that uterus. So if you have an extra set of hands, you can have a partner hold the uterus from the side and just push it over. Why? Yeah. To stop that supine hypotensive syndrome is the same kind of theory as you're keeping that pressure off of the IVC. All right, gynecologic emergencies. So vaginal bleeding can be like caused from trauma. It can be caused from something going on, like an ectopic pregnancy, pregnancy involved, could not be pregnancy involved. I had one of my I call him a mentor. He was one of my partners. He's going to PA school. He told me that any female that is past her childbearing age that has new onset vaginal bleeding has cancer until proven otherwise. So that's something to keep in mind too. Try and keep note of how much bleeding they've had. If they use pads or tampons, make sure you're asking how much they're going through, just so you can kind of get an idea of how much blood is lost. Make sure you're checking for associated abdominal pain. That's kind of like a duh, but make sure you're palpating the belly. And then any trauma to external genitalia. A lot of times, if it's like a sexual abuse situation, sexual assault situation, you want to observe for the mechanism of, that's supposed to say injury, not mechanism of injury. And then consider additional internal injuries. So if we're talking about like a sexual assault situation, this is one of those things that's kind of, it can be a hard thing to deal with. So depending on the patient, sometimes they just want a female in the back with them. So if you can get them that would be preferred. If you do need to remove any clothing to do an assessment, that clothing needs to go into a paper bag. Does anybody know why? Evidence, yeah. But why paper? Why can't it go into like a plastic biohazard bag? Does anybody know? Yeah, it preserves the DNA. It lets it dry in its little state. Doesn't get moved
I was about
around.
to say, if one of y'all didn't answer that, I
Yeah.
was going to throw this chair.
Yeah. So it needs to go in a brown, or it doesn't even need to be brown, just a paper bag. Does it need to be brown? Okay, a paper bag. They're always brown. If severe bleeding is present, examine. A lot of times with these patients, they don't want you looking at them. They don't want you touching them. The first thing that they're going to want to do is take a shower or bath. Is it 7? They're going to want to take a shower or bath because they feel unclean because of whatever just happened to them. Discourage them from taking a shower or bath. It sucks.
And so me and Becca have ran into this. We had a 14-year-old sex trafficking case in Atlanta. When we got there, I put Becca in the back of the ambulance, and I did not open the back doors of those ambulance, or I did not open the back door of that ambulance. She had just gone through a week of being drugged and sexually abused. That's not a place I need to be in the middle of. Becca did her assessment. She did everything. And when she was ready to go, she told me. So if you can do that, emotionally support the patient, try your best to do that, because it's not, Atlanta is one of the biggest sex trafficking places in the world. So you run into it a lot out there. Just support these people. Try to make them as comfortable as they can. If they are like, F you, I don't want to talk to you, okay. Most of the time, PD will be on scene, so any evidence, clothing included, that you take off the patient, it's easier if you just hand it over to them immediately, and not try to like store that stuff, because sometimes it'll get lost at the hospital. So.
Georgia's actually number 2 in the United States. Does anybody know what state's number 1 for human trafficking, sexual assault. Nevada. I actually just Googled this the other day.
Yeah, we
It's
just saw it in
Nevada.
a statistic the other day, which makes sense because Vegas.
Yeah, Vegas. Yeah.
Where do they do it?
Well, so Atlanta's airport, Hartsfield-Jackson, is the most sex trafficked airport in the world. There's more sex trafficking cases that come through that airport specifically than any place in the world. There's a lot of these issues. Like I said, the girl that me and Becca ran into was a 14-year-old runaway out of South Carolina. That some guy was riding down the road, saw her, was like, "Hey, you need to ride somewhere?" And she was like, "Yeah." Jumped in the car, disappeared for a week, and that's where she was able to escape one night and call us. But yeah, just be mindful of these cases. They're very, very sensitive, and the people involved are very sensitive to what's going on. So
Yeah. And then fulfill mandated reporting requirements. So in the state of Nevada, from what I can find, healthcare providers, including you, anybody that is a professional healthcare provider, is a mandated reporter. So that means you are letting the law enforcement know, sheriff's office, PD, whoever is on scene with you. You're letting the receiving hospital know. And then there's also, whenever it comes to like adults, disabled adults, children, there's actually a website you can go on and fill out a form. So whenever you're doing this, make sure you're objective about all of your information that you're providing. Don't be like, I just had a weird vibe. It needs to be objective. Like, I saw this. This is what I evaluated on scene. This is what's leading me to believe that this is going on. And we'll talk about that more on Thursday. There's like a whole slide. What questions do you guys have?
So I know that it was like slightly touched on, but if you do have a miscarriage, so this is something that I ran into in a call that I ran, was a young lady that was pregnant. She called because she was passing clots, bleeding really bad. When we got on scene, she was sitting on the toilet. When we moved her, she was like, "Yeah, I was just passing a bunch of clots." I looked down into the toilet, and she had actually miscarried. The baby was in the toilet in the bottom. She had no idea at the time. So make sure you check your environment with stuff like that. You know, if you walk in and somebody's saying that they have been passing clots, bleeding a lot, you're like, "Hey, have you used the bathroom? Like, where are these clots at?" Check the toilets if they've sat on toilets. The only reason why I saw it is because I had to like stick my flashlight almost in the water, and I could see the outline of the baby in the bottom. So make sure you're checking for stuff like that, because you need to take all of that stuff with you to the hospital. So unfortunately, you might have to fish a baby out of a toilet.
Yeah, take any tissues like that. Take them with you to the hospital. There was a case in Boston 2 years ago. I think it was 2 years ago. A crew went on what they were toned out to as a miscarriage. They took the fetus, tossed it in a paper bag, tossed it on the back of the stretcher. No, they didn't even put it in a paper bag. They put it in a pizza delivery bag. It was like a plastic bag on the back of the stretcher, made it to the hospital. The hospital crew's like, "Hey, let's see the fetus." And they were like, "Here you go." It was a viable baby that was like still breathing, and the hospital revived the baby and the baby lived. So please keep that in mind. I'll try and find the article on it, but keep that in mind. Make sure you're taking that stuff. Obviously, if it's like teeny tiny, not viable, that's one thing. But if it looks like a baby, you should probably assess it. Let me see if I can find this.
And again,
Picture
emotional
of-
support is the same thing with those situations. If anybody in here has ever had a miscarriage, you understand. If you know somebody that has had one, you understand. Support them emotionally, and that's really all you can do. On the backside of it, is try to make sure that they're doing okay. But yeah, it sucks. I had to do the same thing though. I fished the baby out of the toilet with a Walmart sack, and off to the hospital we went. So My baby was not viable though. She had been underwater for quite a while.
I can't find a good picture of a placenta with those little things missing. I'll find it and show y'all on Thursday.
So Thursday, you'll just have a test over OB, and then we'll do chapter 37, and then you'll just have a test over chapter 37. The pre-test, like I said, I'm not going to change those. We'll just leave them how they are. Leave the due dates where they are. But because 36 and 37 are already done, so the only day that's changing is Thursday. So everything else should stay the same. Is there anybody else that needs to make up tests before they leave tonight? I know one person. I haven't looked at all of them, but tonight is it.
I guess it was in Texas, not Boston. But they said the baby was wriggling around and couldn't breathe, so we put it in a bag. And I guess the baby died a few days later, which is crazy.
Oh no, it's New Jersey.
Where do you see that?
And the first line that says, "But the New Jersey paramedics."
This other one said Woonsocket, Texas.
Oh,
okay. So this happens a lot, clearly, as it shouldn't. Yeah, they're getting sued.
I'm telling y'all, bro, you dick around, you can lose a lot of money doing this. So be mindful of what you do.
Yeah, it's crazy. Yeah, it's wild. But anyways. Yeah. Don't be that person. That's all I'm saying.
That's an older one.
Is it? I could have swore the one I saw was like in Boston. And it was like something crazy, like a pizza delivery bag or something. Yeah, happens.
All right. Any questions, comments, concerns? No? What you doing?
I'm just holding the baby.
Hey,
What are you doing?
should we clean up before we leave? You're cute.
You're cute.
Yeah. Oh, yeah. What the freak is that?
It's a little itty bitty tiny thing.
Hey. No. My finger.
Ooh.
No, babe. Hold your hand out.
Oh.
You see what that is?
Yeah, it's the penny. It's a little baby penny.